So I'm going to talk about a topic today that's obviously getting hotter by the minute. In fact, this week we had some news that I'll talk about as well, but it's outpatient joint replacement, now more than ever. So let me first discuss that I do have some disclosures related to this. I'm a consultant for a company that licensed some software on medical risk stratification. I'm a consultant for SCA, and then I have shares in a surgery center. Those are all relevant conflicts. So I think we can all agree that outpatient surgery is being fueled by a number of factors. Surgeon investment's one of them. Surgeon control of their operating room environment. And then more recently in the last year, constrained hospital resources post-COVID, and I'll talk about that and how that's affected our practice towards the end of the presentation. It also, a driver has been episodic care cost control. It's certainly cheaper to probably do it in an outpatient setting in certain situations. And there's some gradual patient demand. I think that's been accelerated by COVID for sure. And we'll talk about that. Here's some projections that were originally put out by Becker's in 2017. And before COVID, we were tracking right along this line. So I think it's probably been accelerated. We'll have to see when the data comes out soon. But we were at 15% in 2016 of hip and knee replacement were outpatient. And then they were projecting to be over 50% by 2026. And I think we're going to beat that thanks to the pandemic that we didn't really anticipate and some of the Medicare's decisions. So, and you can see why Medicare is targeting us to move to the outpatient space. It was a $7 billion annual spend by Medicare for hip and knee replacement. And that was 2014, and the cost probably has not gone down. And of course, everybody knows CMS removed total knee from the IPO list in January of 18. And so hot off the press is a total hip now has a freestanding ASC code. So that's going to probably fuel an additional move of Medicare patients into the ASC. How much, that remains to be determined. Suffice it to say, you got to have a coordinated program. Everybody's got to be on the same page. I'm going to talk a minute about patient selection, something we've done a fair amount of work in, because as Medicare participants move into the ASCs and the outpatient space is something we have to really think about. Patient selection is multifactorial. It's probably one of the most critical aspects as we look at the Medicare patient population. You got to have a motivated patient. Apprehension is certainly a potential predictor of failure. And if a patient in our practice, if they're apprehensive, we just do those patients in the hospital, no problem at all. They have to have adequate family and home support, obviously. They have to be in the right physical and mental condition, particularly if you're going to do them in an ambulatory surgery center. Preoperative narcotics are red flags for us. And they have to be moderate surgical complexity, certainly not high risk. And then we look at their medical risk. That's something we've done some work on. And I would argue that performing young, healthy patients in an ambulatory surgery center or the same day discharge is relatively straightforward, but that's probably a small percentage. We're at a tertiary medical center where we have a lot of Medicare and a lot of sick patients. And so we had to do some work to make sure we were able to do this safely. And if we're going to take these Medicare patients into the outpatient, it's going to be probably a bit more challenging. So we developed something that we've compared against the ASA score, because the ASA score is sort of our traditional way that we look at this and the way most people are looking at it. And just by way of example, this is the original paper in 1978. And you'll notice in the details, it was a survey of about 300 anesthesiologists, about 3/4 responded. And they posed to the anesthesiologist 10 hypothetical patients, and they only agreed on about 6 of those. And so even the author said in 1978 it was useful, but it suffers from a lack of scientific precision. And what we want to highlight here is that ASA does not necessarily correlate with outpatient failure. So a patient example is someone with a poor pain tolerance and a history of a postoperative ileus versus a patient with stable coronary artery disease. And what we've learned over our 5 years of really diving into this is that first patient who's an ASA1, that patient is not going to be in our ambulatory surgery center. Those patients have a high risk of failure to discharge just because of the pain tolerance issues and the post-op ileus, yet they become an ASA1. Stable coronary artery disease, on the other hand, is a patient who we do in our surgery center routinely. And again, the key is stable. So the comorbidity is managed and optimized. So we developed something called the ORA score. I'll talk briefly about it. It's the brainchild of our perioperative medical specialist who does the work. We published on it. It's in 2019, looking at over 2,000 patients. And here's really the take-home message. The x-axis there on your graph is length of stay. The y-axis is the score. And you'll see ASA is in blue. The ORA score is in red. You want something with a steep slope, meaning that it's discerning for early discharge versus late discharge. And ASA is not bad. It's just that it's, you see the averages are 2.1, 2.6. Well, you don't get a 2.6 ASA score. It's 1, 2, or 3. And so it's not as robust at discerning who should be able to go to an ambulatory surgery center. We looked at our statistical analysis, and basically the bottom line is it's very good at having a high positive predictive value and high specificity. So it's good for a confirming test. Here's our readmission rates with that data set, so you know that the methodology we used resulted in reasonable results. Our same-day discharge readmission rate was 0.4, and you can see our post-op day 1 and greater than post-op day 1 were greater, as you would expect. Those patients are sicker, obviously. We have some multi-center data using the score that takes our bias out of it a bit, and similar findings. Same-day discharge readmission rates are about 2%. This was nationwide. And then those who stayed longer had a readmission rate of about 3.5%. So we've learned some things over time that I just want to share with you. These are some of the protocols and lessons we've learned over the last 5 years as we've been doing more and more outpatient surgery. It's evidence-based, and it's based on our own data, and I encourage all of you, if you're doing it, to look at your own data. First thing I would tell you is that we know that the value of perioperative optimization and what you do in surgery matter. And so I like to show this picture of a Corvette assembly line, because when you're in an ambulatory surgery environment, or you're trying to discharge the patient same day, and you do a fair amount of them, the nurses receiving those patients out of the OR have to have a consistent product. So we use a lot of IV fluid resuscitation. We have consistent surgical care, multimodal pain control. Your operative time and your blood loss have to be very consistent. That's why you don't take challenging orthopedic patients for same-day discharge. And that consistent product must arrive in the PACU, so the nurses don't have to deal with fluid shifts, patients with pain out of control, et cetera. That'll ruin your program pretty quickly, especially if you're in a freestanding ambulatory surgery center. One of the things that you hear a lot about is fluid management, and we emphasize euvolemia. Now, a lot of people talk about forcing patients to drink ahead of time. We do not do that. There's some literature that having patients with too much fluid can actually increase the rate of urinary retention. So we just like a euvolemic state. We let them drink clear liquids up to 2 hours before surgery, things like Gatorade, coffee with no creamer, et cetera. And then intraoperatively, we give everybody about 2 liters of fluid almost routinely, plus or minus depending on their medical comorbidities. Preoperatively, we do the typical multimodal pain meds that we're all familiar with now. For knees, we do a native canal block and a para-articular injection. And for hips, we don't do anything other than short-acting single-shot spinal. Post-operatively, continue with the multimodal meds. Antibiotic prophylaxis is something that comes up quite a bit. And I think one of the papers that Craig Della Valle's published that I think has shed some light on outpatient surgery. When they looked at a large data set, they basically found out that there were some risk factors for infection after and for readmissions. And it was the things you would imagine: obesity, diabetes, and older age. And the most common reason for readmission was infection. So the verdict's not out on how to deal with these with our short stay. I know there's a lot of work going into whether or not you have patients just get 1 dose or send them home with oral antibiotics. We have some bias because we have a protocol we developed, but we send people home with oral antibiotics so that they get a little bit more extended coverage. And that's also based on Craig's data that you saw there. Blood conservation is important, and I think it's important to remember we're not doing this to minimize transfusion. TXA has taken away transfusions. We're using all the things, all the modalities that we can to minimize blood loss, because it's minimizing postoperative anemia and hypotension, things that cause patients the potential for not being discharged home on time. So we use computer navigation. You could use PSI, you could use robotics, whatever you want. We just don't like drilling a hole in the femur, and we have some data that showed that saves an additional gram of hemoglobin, and that's particularly important in the outpatient setting. So we've had a number of issues over 5 years that we found are the most common reasons for failure. Urinary retention is one. We've published on it, and I would direct you to that paper that you see there, because it highlights some things that your anesthesiologist can do to minimize it, and things to avoid. Hypotension is one. That's why our fluid protocols are the way they are. Nausea, intractable pain, motor weakness, and then hypoxemia. So when we do total knees in our ambulatory surgery center, we use the multimodal pain that we talked about. We also don't use a tourniquet to minimize any issues where that's concerned. So we currently screen for those in the office for some of those. So I ask patients, when I look at who's going to go home for who's a potential candidate, when I'm seeing them for the first time in the office, I screen them for those issues there. Do you have uncontrolled obstructive sleep apnea, history of POR, which is urinary retention? Do you take any chronic opioids, nausea, and poor home support? If the answer to all of those is they're negative and they're good to go, then we apply Aura and those protocols that I mentioned. In over 5 years, we've had no patients failure to launch. Now, I don't like that is we've had a couple readmissions, but we have not had any patients who didn't discharge home the same day. Now, we're not aggressive. We don't do 90% of our patients as outpatients, obviously, or same day discharge. But so we're still relatively conservative, but we've been happy with the program over half a decade. So we wanted to look really, and this is the last thing I'll talk about, is the impact that COVID has had on outpatient surgery. We retrospectively reviewed over 1,300 primary hips and knees at our hospital. And all the patients are given the opportunity to choose whether they go home the same day or the next day, and they can choose whether the ASC or the hospital. And here's our data. I think you'll find very interesting. The 2 years prior to COVID, we did about 20% of knees as outpatient, and about 27% of total hips as outpatient. And you can see their mean ages. Since resuming surgery after our mandated 6-week pause in March for COVID, look at those numbers. 51% of our total knees now go home the same day, and 47% of our total hips. And you can see that the ages are older. So there's certainly, and we hear this all the time in our clinic, a need, a patient demand to not be in the hospital with the sick patients. Also, in terms of our ASC, this just happens to be another patient preference thing. We don't push them one way or the other. Our volume year to date is up almost 100%, double the ASC what it was last year, and it's down about 17% in the hospital. So in summary, I think outpatient hip and knee replacement is definitely here to stay. It's the future, and I think it helps with hospital consumption, minimizing consuming resources. Patients are happy with it. You have to align the stakeholders and always put patient safety first. So thanks again for the opportunity to present to this group, and happy to take questions at the end of the program.